Thank you for inviting me today. I'm Jeff Meyerhardt. I'm a medical oncologist that specializes in GI cancers at the Dana-Farber Cancer Institute in Boston. And I'm going to spend this time reviewing some concepts that are emerging and important in treating patients with early stage or non-metastatic colorectal cancer. So the first few studies that we'll review are really focused on circulating tumor DNA, which has really been of great interest for several years now. And there's a lot of different platforms to be able to measure circulating tumor DNA and measuring what people describe as molecular residual disease, or MRD. And it's a very powerful tool. And the question is what can we do with that powerful tool, and what settings it should be applied in, and which patients, and how, most importantly, how could it inform us regarding how to treat our patients. So I'm going to first look at this trial. This is the circulating tumor DNA for MRD in patients with stage 2 and stage 3 disease, a final analysis of the BESTOKE CRC cohort. And so the BESTOKE effort is an observational perspective, observational study using one particular informed assay to understand both how that affects prognosis and potentially how it informs treatment decision in providers of patients with stage 2 and stage 3 colon cancer. So the way this is set up is you can see here the different time points of when blood is collected in patients who had colorectal cancer. We'll focus particularly in the after surgery time period, where there was blood collected somewhere between 2 and 6 weeks after surgery, somewhere around 6 plus or minus 2 weeks after that, and then 12 weeks and 20 weeks, and then a surveillance program. So multiple time points collected. There's also questionnaires that were sent to providers, and part of the questionnaires is asking how did it potentially inform their decision making, and then there's patient-reported outcomes that were also collected in these patients. And what we can see from these Kaplan-Meier curves is what we know really from most trials, and we'll see pretty replicated in several of the trials that we'll focus on today, is that having positivity of ctDNA postoperatively is very prognostic in terms of disease-free and ultimately also overall survival. And so you can see here in patients with stage 2 disease compared to stage 3 disease, a hazard ratio greater than 10, 11.23 for stage 2 disease, and 8.3 in patients with stage 3 disease. So again, a very prognostic marker in terms of either recurrence or death, which is the definition of disease-free survival. And what we can also see is that if you look at the first surveillance time point, so again, after receiving adjuvant therapy, that also is very predictive of outcomes. So people who either were negative and became positive, or positive and remained positive, is also significantly associated with worse outcomes, with, in this case, a hazard ratio of 20. So very significant effect. What we learned from this is a few things. One is, again, they asked physicians how this affected their treatment decision. And what we learned from that data is about 16% of those decisions on what to do about adjuvant therapy were influenced by the data. Doesn't mean, again, that it affected their outcomes or predicted their response to therapy, but 16% of the providers who participated in BESTOKE with their patients changed their decision, either escalating about a third of the time, or de-escalating about 60% of the time their adjuvant therapy based on the results of the ctDNA. We also learned if you clear ctDNA, that's associated with improved outcomes. And what we learned is that those who were positive, particularly stage 3 patients, who received adjuvant therapy compared to observation had an improved disease-free survival, and that those who were MRD negative, so after surgery, who did not, who received adjuvant therapy, didn't seem to have a significant benefit in terms of outcomes. But I think the important thing, and this is really the issue with the field overall, is these are observational studies. So what, though we learned that people may have changed their decision, but what really influenced giving some patients adjuvant therapy and not is undoubtedly confounded. And so you can't really take the data and say that because the positive people who got adjuvant therapy seem to do better, that definitively says that that should define who should get adjuvant therapy, because that decision for therapy is not controlled and it's not a randomized study. But again, certainly suggestive data of the potential benefit of adjuvant therapy in positive patients. This is a second study by a group in Japan that looked at MRD and survival in resectable colon cancer. And again, very similar results that we saw with the other study, that both at the MRD window, so after surgery, highly predictive of disease-free survival, very significant hazard ratio, 11.99, and similarly, a highly statistically significant overall survival. And when you look at surveillance, you can see again that having positivity after the end of treatment for surveillance is also highly predictive of outcomes, both in terms of disease-free and overall survival. They looked at how can we think about this, particularly with certain molecular alterations, and this is looking at BRAF V600E, which we know from other studies that patients who have early stage disease that have a V600E mutation do have a worse outcome. And you can see, though, if they are ctDNA negative, they still have some recurrences. There's clearly recurrences that are occurring within the first few years after surgery, but those who are ctDNA negative have a much better outcome than those who are positive after surgery that unfortunately have a very significant drop in their curve. Now, I think the other thing to note is these are subgroup analysis of the observational study. You can see that the ctDNA positive patients is only 11 patients, so it's a very small number of patients in this endpoint. But again, suggestive that this is important in multiple different type of mutations, including those who are MSI high, those who have certain KRAS mutations, those have ERB amplification, the HER2 amplified tumors, etc. And what we also saw, which was interesting, a little expanded upon in this study, is that if you take patients who were positive at the MRD time point, so soon after surgery, and those who did not clear their ctDNA, those patients had a significantly worse outcome. Those who sustained clearance, so looking at a surveillance endpoint, seem to do much better. And then there's an intermediate group that has transient clearance, so became negative and eventually became positive, who do relatively better. But ultimately, again, it's defining those patients as undoubtedly having metastatic disease that, whether detectable or not, initially will ultimately have metastatic disease, and that also translates to overall survival. So in this and the other thing to know about the Galaxy trial is it was a mix of stage 1 to 4 patients. The majority of this cohort did not receive chemotherapy. Again, it's highly prognostic of outcome. Those who received adjuvant therapy, who were ctDNA positive, which is really a small number, 181, had actually received adjuvant therapy. 38 sustained clearance, 31% transient, 31 no clearance. So it does suggest that chemotherapy for some people seems to lead to clearance. Again, as was shown, a good portion of those patients will remain disease-free, but not all of them. And those who get no clearance will have a significantly worse outcome. And again, it's not a decision. It's an observational study, and again, the issue of who actually receives chemotherapy or not is not controlled in this setting. The next study will look specifically at a subgroup within the Circulate Galaxy cohort, and these are patients who had resected colorectal liver mets. So this study, which was published in November, looked at that subgroup of patients. And again, a very similar. Now, these people, again, because they already had metastatic disease, will have a worse outcome almost by definition. So as opposed to when we saw for the earlier stage patients where a ctDNA negative patient seemed to have, what looks like remaining disease-free long-term in the 85 to 90% range, you can see these patients in the liver MRD group do seem to have, even if they're negative, disease-free survival of 2 years of only about 70 to 75%. But again, if they're ctDNA positive after resection of liver mets, they do worse, and similarly, similar results that we see for surveillance. If we look at potential predictive value, again in an observational setting of adjuvant chemotherapy in this setting, and I will make sure it's noted that you can see from these Kaplan-Meier curves and the number at risk that the numbers are pretty small here, right? So these are patients who were ctDNA positive or ctDNA negative or ctDNA positive. The ones that were negative who received adjuvant therapy compared to observation doesn't have a significant difference, though there is an absolute difference, and there is some separation of the curve. So again, in the population that had resected liver metastases, receiving adjuvant therapy, not statistically better, but does seem to have some a sense of some improvement. And those who cleared seem to have a much better outcome, though only a small portion of them cleared. And you can see the at-risk in the bottom left Kaplan-Meier curve is a very small number of patients. And for those who were positive, again, they do worse in terms of overall outcome either way, but those who receive chemotherapy seem to do better. And that hazard ratio actually is 0.07, which is sort of a little unheard of in most medicine. But again, the numbers are very small. But clearly, the patients who are positive and only are observed, unfortunately, have a very poor outcome. But again, that is likely confounded for some of the reasons of why they did not receive adjuvant therapy. And so there's 190 surgically resected patients. None of them had gotten preoperative therapy. 32% were MRD positive. Only a quarter of them actually received chemotherapy, which I think for most of us practicing where you had a patient who had liver metastases that were resected and look on imaging to be disease-free would be providing them adjuvant therapy. So it's only a small number. And as I pointed out earlier, though the MRD negative patients, the difference between chemotherapy and observation was not statistically significant, there's still actually a 10% difference at 2 years. And so should be certainly a consideration in those patients as well. Our group presented these data from the Alliance CLGB SWOG 8702 study at GI ASCO this year. And the study itself, just to give a background, it was a randomized clinical trial that compared 2 questions, 3 versus 6 months of adjuvant FOLFOX therapy, specifically in stage 3 colon cancer patients, and celecoxib placebo that was started at the time of adjuvant treatment. The study itself, primary endpoint was the celecoxib question. The hazard ratio was 0.89. We published it several years ago in JAMA. We have since looked at several molecular biomarkers related to potential subpopulations that may benefit. We collected tumor blocks and blood in many of the patients. And we did whole exome sequencing in over 1,000 patients, and we matched their blood and we thus did an informed ctDNA assay in that population. So it's about 960 patients that are included in this analysis. What we showed here is that very similar to other results, and this is looking at MRD, so soon after surgery, before they started receiving adjuvant chemotherapy, that patients who were ctDNA positive had a significantly worse outcome. Again, we keep seeing these hazard ratio in terms of a prognostic value of 7, 11 to 13. So it's really a very prognostic a marker in patients who have stage 2 and stage 3 colon cancer. But and that also translated into overall survival. But then when we looked at the subgroup of patients who received celecoxib versus placebo, we saw a result that frankly was a little unexpected. What we see here, just to get a sense, is these more solid lines are those who were ctDNA negative, again, at the time after surgery before starting chemotherapy. And you can see there's really no difference between the patients who received celecoxib versus placebo. But those who were positive, who were ctDNA positive, you can see there's clearly a separation in the curve, and the hazard ratio for that subpopulation, 0.55, was statistically significant with a significant p-value. Now, the caveat of these data are that when you look at an interaction, and the way interactions work, which I know is not necessarily always intuitive, you're basically, when you're looking at associations between two things, two subgroups, you're basically creating curves and lines, and you're really deciding how different those two lines are, and is it enough of a difference to say those two subgroups really have something different happening to them. So in this case, is the group that are negative versus positive, is the differences we're seeing between celecoxib and placebo just by chance, or there truly are different subpopulations that are defining the relationship or association differently. And so there's not a statistically significant interaction between those two groups. And this is looking at overall survival, which again shows a significant difference in the subpopulation, but the interaction term, 0.2, is not statistically significant. So these data, again, support the highly prognostic value of ctDNA. Celecoxib seems to benefit patients who are ctDNA positive, but the P interaction was not significant. There's a benefit in patients with the data I didn't show here is we looked specifically at a subgroup of patients who are PIK3CA wild type and who are mutated, and that benefit is seen in both of those subpopulations. And I'm going to talk a little bit more about what is PIK3CA and why it's important in a later study. And again, the data are suggestive but not definitive for using celecoxib when patients are ctDNA positive. One other study that we're going to look at, focus on ctDNA, is this study, the dynamic study that from the group at Peter Mac in Melbourne. And this is looking at the 5-year updated results of the dynamic trial. And again, that was specifically in patients with stage 2 colon cancer. So the way this study worked is it was patients who had stage 2 colon cancer. They underwent a resection they had staging scans within 8 weeks. They had a tumor-informed ctDNA analysis done at week 4 or week 7. And they had both bloods drawn at those two endpoints, but then they were randomized to either using the results of their ctDNA to guide management or doing what you would standardly do. So the way we all make decisions on who receives adjuvant therapy for patients with stage 2 colon cancer, where we use, if it's a T4 disease, if there's perforation or other clinical factors to determine who should receive adjuvant therapy. But those who were CT-guided management, the recommendation was for those who were ctDNA positive, either at week 4 or week 7, to receive adjuvant therapy, either fluoropyrimidine-based or oxaliplatin-based, or for those who were CT negative to have observation. And then they were followed by the way we standardly follow patients in surveillance. So using the ctDNA results to determine whether you receive adjuvant therapy or not versus what you would do clinically, there was no difference in terms of recurrence-free survival at 5 years between those two groups. And similarly, there was no difference in overall survival or disease-free survival. What we can see is that the patients who were ctDNA negative versus ctDNA positive, you can see that there is, again, a prognostic value to ctDNA, where the people who were positive, and again, some of those would have received adjuvant therapy, either because that was the recommendation because they were using ctDNA guided management, or they were ctDNA positive because they had just clinical management. You could see that there's those people do worse if they're ctDNA positive, both in terms of overall survival. And then if we specifically look at T3 versus T4, for those who were negative, they again are prognostic in terms of what we know clinically that a T4 disease does worse, even if you're negative. But the ones who are T3 ctDNA positive do quite well. And so it was a non-inferiority design for a standard of care to ctDNA management, which can either be interpreted as using MRD to determine whether you receive adjuvant therapy. Doesn't change outcomes, because at the end of the day, the group that had ctDNA management did the same as if you didn't get the ctDNA. Or you could use it, or you could interpret it as by checking MRD, we use less chemotherapy in patients with stage 2 disease. The issue is it actually is not that much less chemotherapy. In fact, the less patients on the ctDNA management actually received chemotherapy as we expected, but they actually, more of them got oxaliplatin because they were ctDNA positive. Small percent, 9.4 versus 2.7 of the overall population. But again, using the ctDNA management, they overall got less chemotherapy, but more of them got oxaliplatin, which is honestly the chemotherapy that can be more problematic for patients because of the neuropathy. And the median time to start therapy actually increased by about a month. So, and that is some of the issue with checking ctDNA in these patients to use it for a decision regarding adjuvant therapy is you have to obtain the tumor, you have to obtain the blood, you have to send it in, it has to get analyzed. And so you could see the median time from surgery for those who did receive chemotherapy in the standard no ctDNA checking arm was 53 days, and those who had ctDNA guiding management, it was 83 days for those who received chemotherapy. This is the last topic I'll talk about related to ctDNA is the current ongoing NRG study. So the NRG study is actually asking two questions. So it's going to take patients with high-risk stage 2 and stage 3 disease who had a resection, and ctDNA is going to get checked. And those who were ctDNA negative are going to be randomized to a potential de-escalation plan, which is either receiving what we would standardly offer these patients, which is capecitabine, oxaliplatin, or FOLFOX, or have surveillance with serial ctDNA measured. And if they became positive, then go on to a randomization of then receiving chemotherapy or a dose or a chemo escalation to FOLFIRINOX. Those who were originally ctDNA detected, those are going to get randomized either to oxaliplatin and fluoropyrimidine or FOLFIRINOX, because of the concern that they have a much worse prognosis, and trying to look if that increasing the intensity of chemotherapy will overall improve outcomes. So again, the study is set up to look at those two questions, comparing disease-free survival in ctDNA negative patients following resection of colon cancer treated with immediate versus delayed chemotherapy based on serial ctDNA. And then the second question is looking at disease-free survival in the positive a cohort comparing FOLFOX to FOLFIRINOX. The study as of February of 2025 is 1/3 accrued, and I would strongly encourage those who have this open at their sites to continue to enroll patients, because it really is an important question how we can think about this. The second topic that I'll focus on is related to immunotherapy in early stage, both colon and rectal cancer. So these are the more updated results from the group at Memorial that looked at giving a checkpoint inhibitor to MMR deficient locally advanced rectal cancers. The drug used in this trial was dostarlimab. Patients who had stage 2 or stage 3 rectal cancer were found to be deficient mismatch repair proteins by immunohistochemistry, were treated with dostarlimab. They were then evaluated, and if they had residual disease, the plan was for them to receive chemoradiotherapy and then potential surgery versus non-operative management. For those who had a complete clinical response, to move on to non-operative management. And there's serial biospecimen collections along the way and a very close follow-up of these patients. And it really has been a stunning result so far. So you can see here, this is people at different time points of where they are, but 100% complete clinical response. 42 patients have already, at the time of this analysis, had already completed their dostarlimab. The median follow-up in this cohort so far has been a year and a half, but there are multiple people, quite a few years out even now, and continue to not have a recurrence in this population, which is really sort of unheard of in this population. So again, these are patients only receiving dostarlimab, not receiving chemotherapy, not receiving surgery, and not receiving radiation. And those patients will continue to be followed. The caveat is it's a small subset of rectal cancer, so only about 5 to 10% of rectal cancers. Again, nobody's received any other therapy. The sample size is still modest, but continues to hold up. The questions of this is this applicable to other checkpoint inhibitors? Most of us think probably yes. How many doses are really needed? In this study, they receive up to 6 months of therapy. Will there be later recurrences that we just are getting delayed? We just don't know, and longer follow-up is needed. And the question of how much therapy is needed, I think, particularly comes out when you look at these two studies from the niche group that looked at immunotherapy in colon cancer, again, mismatch repair deficient colon cancers. And this setup, and this is looking specifically at the niche 2, is that patients received 2 doses of treatment and then underwent surgery. And you could see the vast majority of them are having pathological responses, and 68% have actually complete pathological responses at the time of surgery. And you don't really ever see waterfall plots like this in really no other setting. So again, a remarkable finding of how effective immunotherapy is for early stage colon and rectal cancer. They do actually collect ctDNA in these patients, and you can see here that at baseline, the vast majority of them are ctDNA positive, and after the 2 cycles of therapy, about half of them become negative. But right before surgery, 80% of them negative, and then after surgery, 100% are negative. And so far, the 3-year disease-free survival is 100%. And it's really, again, an unprecedented finding. And in this case, ctDNA does seem to predict what they're seeing, what they learned about the pathological findings at the time of surgery. So they only receive 2 doses of nivolumab. They actually only get 1 dose of ipilimumab. The 2.7% received chemotherapy after surgery. 3 of the 14 who had positive lymph nodes, and 1 of them actually had residual tumor in the specimen. So it's a very small percentage of patients even getting chemotherapy after. they really didn't delay surgery for most of these patients. The plan was within 6 weeks from study enrollment, so it really didn't delay chemotherapy or these patients actually getting surgery. What we also learned is radiology didn't actually predict response very well. So there was only a radiological response seen in 2 of the 75 patients with a path CR. So that's the one caveat of this is really the challenge, both in identifying patients who are the right stages for this, and then being able to predict who potentially maybe surgery shouldn't be necessary. And I think that's the challenge, because again, it's not 100% path CR rate, it's a 68% path CR rate. So that is a challenge for these patients, but they do avoid chemotherapy. The difference in response and duration for localized therapy compared to metastatic disease. And I think that's really an important other thing. What we learned both from the rectal study and the colon cancer studies is that patients who have just localized disease seem to have a much better response to immunotherapy versus those who have metastatic disease, where the progression-free survival with metastatic disease combined with chemotherapy is 71%. It's not anywhere near. And that's just a response of at least 30%. The niche group also then proceeded with a second study looking at another combination of chemotherapy, a LAG-3 inhibitor, nivolumab, a very similar result to what we saw with the niche 2 data. So again, a very high pathological tumor regression and complete response rate in patients receiving nivolumab and a LAG-2 inhibitor. It's again, these were again 2 treatments. They were 28 days apart. Very similar results. Unclear if you really need the combination. So this really raised the question: what would be the results of nivolumab alone? It raised the question: is a LAG-3 inhibitor better than a CTLA-4 inhibitor? We don't really know. It did seem to have a higher rate of some immunological toxicities, particularly thyroid dysfunction, adrenal insufficiency, colitis, compared to nivolumab and ipilimumab. But again, there needs to be some caution with cross-study comparison. And this is looking at some ongoing studies that are looking at PD-1 antibodies, either as single agents or in combination with chemotherapy or without in this setting. There is a study looking at single agent dostarlimab for mismatch repair deficient tumors across multiple cancer types. And you can see here ones that are deficient in mismatch repair proteins: colorectal cancer, gastric cancer, small bowel, pancreas. So a whole host of different studies. They have a variability in terms of response rates in these populations. And you can see here, when we look across all different cancers that are DMMR positive, you can see here the progression-free survival across those different cancer types. And it really confirms what we learned from other PD-1. The other thing about this study is it included POL-E, those who actually have molecular alterations that lead to high TMB, tumor mutational burden, that they're responding to chemotherapy, and there's a long tail to the curve. So the last study I'll present is a study of aspirin in this population. The background of this is that there was an observational study published in the New England Journal several years ago that looked at patients who were receiving aspirin, most of them for reasons of cardiovascular reasons, who had colon cancer. If their tumor had a mutation of PIK3CA, an alteration, activating mutation, that they seem to have a markedly improved or more significant benefit to taking aspirin than those who did not have a mutation. And the hazard ratio was about 0.5 in that study. And that's been replicated in a few other studies. In the CLGB 8702 that I showed earlier with celecoxib, the subpopulation that had PIK3C mutation also had about a 50% improvement in outcome in terms of disease-free survival for the subpopulation that was PIK3CA mutated versus those who were wild type. And those data led to now several studies, and this is the Alaska study that was presented at GI ASCO this year, specifically in colorectal cancer patients who had a PIK3CA mutation. They were a population that received chemotherapy with aspirin or placebo, or if they weren't going to get chemotherapy, they only received aspirin. 3,500 patients were screened. They created two populations, the hotspot mutations of PIK3CA in exon 9 and 20, and then a whole host of other mutations that also lead to activation of the pathway. They were, in each of those groups, they were randomized to either aspirin or placebo. The primary endpoint was disease-free survival. The pre-planned analysis was focused particularly on those in the hotspot mutations, but then also looking for secondary analysis in the other mutations. And what you can see here, both in the hotspot and the other mutations, there's a significant benefit in terms of disease-free survival. And again, that 50%, which has really been consistent across multiple studies, has a ratio of 0.49 for those taking aspirin versus placebo. This is looking at cumulative incidence of colorectal cancer recurrences. The dose of aspirin is 160 milligrams daily. Their conclusions was it can change clinical practice for about a third of the patient with non-metastatic colorectal cancer. It's repurposing a safe, inexpensively, globally available drug. And it does point out, which is what we don't normally do, is look at molecular alterations in early stage disease, but potential need to do that to be able to identify these patients. So it's the first randomized studies to show a benefit of aspirin in a subset of colorectal cancer. And as I said, the hazard ratio is very similar to what we've seen in a randomized study related to celecoxib that uses as a secondary endpoint, as well as observational studies for the PIK3CA mutated patients. So that is a little bit of a wrap-up of how we think about ctDNA, immunotherapy, and now aspirin in early stage colon and rectal cancer. Thank you so much.